And our bank, Dan Williams, please. Dan Williams, dwi cadeirydd y bwrdd prifysgol 2 Abertawe. Croeso cynnes i'r gyfarfod cyffredinol blynyddol heddiw. Croeso arbennig I aelodau'r cyhoedd a'r lein. So good afternoon, I'm Jan Williams, I chair the board of Swansea Bay University Health Board. I'd like to extend a warm welcome to today's annual general meeting and to any members of the public who have joined us online. Swansea Bay University Health Board spends £1.7 billion of public money, and we have 12,800 whole-time equivalent staff, and we are responsible for the population health, public health, health protection, and health and associated care services for 400,000 people across Swansea Bay and Meath. The board has a number of roles and responsibilities. We both look to the future in setting strategic direction. We build and sustain strategic partnerships because we can rarely work on our own. We have to ensure that we keep the risks facing us under oversight constantly. And we've also got to ensure that we deliver against the in-year plans that we approve. In everything we do, we have to maintain good governance. Working with our staff, we have to set the right tone and the culture for the organisation, and we have to listen carefully to families and communities, our partners and stakeholders, before we make any decisions. We have to conduct our business openly and transparently, and we have to give people the opportunity to ask questions of us and to influence our decisions. And one of the ways we do that is through an annual general meeting. And this is a formal platform for the board to hold itself accountable and to be transparent by informing members of the public about what we do, the progress that we've made. We also give people the opportunity to ask questions, voice concerns, and to contribute to our planning for the year ahead. There are some questions that we cannot take in an annual general meeting context. We can't take questions on matters that aren't within the powers and duties of the health. We can't take questions on matters that are defamatory, offensive, or related to individual members of the public or staff. We can't take questions on those matters that have been previously addressed by the board through another process, like a freedom of information request or through the NHS complaints process. And we can't take questions on matters that would require the disclosure of confidential or exempt information. Anyone who does want to ask a question, we will do our very best to help you frame it in a way that we can answer, or we will help you take it outside the meeting. So this afternoon's annual general meeting focuses on the 2024-25 financial year ending the 31st of March 2025. And both Abby, the Chief Executive, and I joined Swansea Bay in 2024, and we knew that we were joining at a time when there was much to celebrate, when we'd had significant achievements, for example, in planned care, meeting a whole range of ministerial targets. We had a raft of work underway to improve health and well-being, to reduce inequalities. We did some major work on partnership working, particularly with Howard, and we knew that we were coming into an organisation with some world-class services. 24-25 was also a mixed year, however, because we had significant challenges in maternity and neonatal services, and Abby and I came in as the independent review was conducting that review. Major issues around mental health and learning disability services, and we have set a transformation program, and particularly challenges around unscheduled care and in the emergency department at Morriston. The board will always be grateful to Charlie and Joe, 2 ED nurses who came to our January 25 board to share with us just how challenging it was working in the department and caring for patients in an unsuitable environment. As we'll hear this afternoon, we responded constructively to all these challenges, and we have safety and quality improvement work underway across the organisation. We also faced major financial challenges, and these remain with us, and we will hear about those this afternoon and how we are going to bring ourselves through the deficit position we find ourselves in currently and return to financial balance. Now, throughout the year, our talented and dedicated staff have worked tirelessly to give patients and service users the very best care and support in ever-changing and difficult times. And as board members, we are grateful to all our staff for everything that they do day in, day out. So we are now going to start our presentation on 24-25. We have a number of presenters, all of whom I will keep strictly to time. And also we do have a Welsh translation service available should anyone want to ask questions in. Abby, at that point, I'm going to hand over to you, please.
Yeah, thank you very much, John. And it's really a pleasure to be here this afternoon, my 10th month being in the Health Board. On one hand, it feels like I've been here a very long time because I feel like I've received a very warm welcome from colleagues around this table and staff right across the organisation. And on the other hand, it feels like I'm just getting going in terms of the work that we need to do as an organisation, as a team. And I come here today really pleased with the progress that we're making on behalf of our patients and populations. So a couple of things I wanted to add, Jan, in addition to the introduction you've given us. I'm really grateful to Richard, particularly in terms of the handover from interim chief exec and supporting me as I arrived into the organisation, getting up to speed very quickly with how we need to do organise ourselves and what we need to do in the last 6 months of the financial year just gone. And also to the interim directors that we had in post. Colleagues will probably be aware we had a number of interim roles in place at executive director level. And I'm really pleased to say that we filled those posts very quickly and really pleased to welcome new colleagues who will introduce themselves today. Anne-Marie Davis, who's absent on leave today, who've joined us and really quickly got up to speed together. So as a leadership team, we are working hard for our patients and populations to make sure we are getting the organisation in the best possible shape so that we can deliver on the agenda that we've got ahead of us. And later on the agenda, I'll be launching our refresh strategy, which is a really good opportunity to set out how we are going to work together with our local communities, with our partners, to work hard to improve the health of our population and particularly tackle some of the really entrenched health inequities that we've got seeing in our populations and actually widening in our populations, and we are very focused on that. And also how we improve the quality of our services. John, you've talked about some of the priorities where we've identified the need to make improvements. And what we've seen, and when we sit here this time next year, we'll be able to really talk about and demonstrate how we've done that and delivered demonstrable improvements in terms of the services, building on the great work that we've had in train already. And for me, the real test is around the feedback we get from our patients. So again, Liz will touch upon the importance of patient experience and patient feedback. We've just spent an hour with our stakeholder reference group, which for members of the public is an important part of our advisory machinery. It's one of our 3 advisory mechanisms. And again, that being a really important place where we hear from members of our community in terms of how we are doing and helping us think through how we transform and change the services that we're delivering where we need to make those improvements. Colleagues will be aware that we have a number of services under particular scrutiny. We have an escalation framework that's agreed with Welsh Government, and as set out in the presentation, we have a number of services that are in escalation, and we are working at pace to ensure that we can deliver on the particular points of improvement that we need to make to de-escalate populations and communities. And the final thing I'd like to say, John, perhaps 2 things. Firstly, just coming back to our communities and populations, one of the things you get to see as a chief exec is many pieces of correspondence across my desk, and some of them are difficult to read because they do give us a reflection back on where it's a complaint or we've not got it right for an individual and a patient. experience has not been what we've wanted it to be, but we also see letters that describe fantastic care and examples where we have made life-changing differences to patients. And again, Jan and I had an example of that this morning when we met with a patient who'd been through one of our cancer pathways. And it's important that we hear both, and it's important that we remain open and transparent. Hear the things that where they haven't gone as they should have done for patients and families and communities, but be committed to being transparent about those things and demonstrating how we're going to work together to deliver improvements. And also for our staff, Jan, you talked about the 2 colleagues who came. That must have been a really daunting experience of them coming to the board and sharing that experience. I bumped into Charlie when I visited the department last Monday, and it was great to see the kind of experience of the transformation that the service has delivered, starting that work in the new year. And the teams have done a fantastic job. And the demonstration of our teams when they come together, focused around a problem, using good techniques around innovation and improvement methodology to deliver better outcomes for our patients, it's a really good example of how we can do that well. What you'll hear as we go through the presentations are our other agendas that are really important to helping us deliver excellent patient care. So our research and development work that Richard will touch upon, that is a really important part of our work that perhaps is sometimes seen behind the scenes. But we know that the more patients we get to have the opportunity of research and experience, being part of trials gives better outcome and quality of patient care, and also helps to new knowledge around how we can respond to the challenges that we have in healthcare. We've also got a really important role in terms of teaching the next generation of a whole range of clinicians. So our relationship with the university is really important in that regard. And again, we're refreshing and strengthening that relationship and looking at how we can work with Swansea University, but our 2 other universities in the region, Trinity St David's and Aberystwyth University, as part of our wider collaboration with HALDAR. Collaboration is a really important part of the way that we go about our business. Yes, collaborating with our staff, colleagues, and I'm very grateful to the colleagues who sit around the partnership forum. That's a really important place where we can come together with our staff representative colleagues to talk through the issues and the challenges that we face together, and how we really implement the workforce plan that Tina will talk about a little bit later on. And then I think the final thing I just wanted to touch upon is the relationship with our local authorities too. We've worked to improve those relationships, strengthen how we work together across the health and social care system, because for many of our patients, it is almost irrelevant whether their need is met by social care or by health. They see a single team of people coming into their front door at times of great need. And we've made really good progress, I think, in terms of developing our approach around single pathways of care right across health and social care. And I think colleagues, Craig, are at meeting, it's either today or tomorrow in Welsh Government to give an update on the progress we're making there. And again, when the colleagues from ED came along to the board in January, we were talking about over 200, nearly 300 delayed pathways of care, which is patients who have got stuck in the system in terms of their acute episode of care being completed, and us needing to work closely with partners and carers and families to ensure we get those patients home. And we've seen a good improvement. We're on a trajectory improvement, and that frees up beds for the whole system improvements that we are seeing coming through. So the end point at the end of March was the year we're talking about. We were starting to see some of those dials really shifting, and we've seen the continuation of that into the first half of this financial year. So I think we've got a really strong platform on which we can build and develop the progress that we're making in a way that's transparent, open to the challenges we face. And I guess the willingness of this board to take some of the difficult decisions that we will have to face, particularly in light of the financial backdrop that Darren's going to outline as we go through. We are living beyond the financial income, both through the allocation and commissioning income we receive. That is not as a sustainable position, and we need to work hard, as we have been doing, to get us to a place where we are sustainable and can invest upstream in more prevention. We can enable the digital enabled healthcare, and we can deliver more of our care out of acute hospital settings in our primary community environments, and we'll pick up on that as we talk about the strategy. That's all from me. Thank you very much.
Thank you. I said at the start that we are a strategic population health body, and we're going to begin our presentations with one from Professor Jill Richardson on our population's health. Jill.
Thank you. Thanks very much, Jan. and Abby. Just to kick off our presentation today, wanted to just remind us all that we have a population health strategy, which has a very nice diagram, which shows that we have been slightly ahead of Jeremy Miles' stated intention that Wales becomes a marmot nation, because my predecessors have worked very hard with the team on getting a better future for all, our health, population health strategy. The Marmot 6 policy objectives span the life course, and the sixth one on strengthening the role and impact of ill health prevention does talk about prevention, and we have, as a team, delved a little bit more into this since I began 6 months ago. And we're looking at using the core 20+5 model, which is something that is used by the Office for Health Disparities in England, to look at the 3 main causes in our area of premature mortality, which are the cancers, the cardiovascular disease, and respiratory. And we've been focusing in depth on cancer screening, and especially on the inequities in our community in just achieving high uptake in cancers such as bowel and cervical. And we're also been concentrating on vaccine equity, trying to increase the uptake within our most vulnerable. We also continue to keep our population safe through outbreaks and environmental incidents, through our continuous health protection work, and also through our immunisation team. And we are a top performing health board in Wales for the human papillomavirus uptake amongst school children. Our Healthy Schools and Healthy Wales teams have been looking at whole school mental health and access to food. And if we could go to the sustainability slide next, please. And my thanks to Marie and to Karen and the sustainability team. They have compiled this slide, but basically we have a comprehensive approach as a health board to this. We have been taking our responsibility as an anchor institution seriously, and we are the 5th largest global emitter of emissions. So we really have a lot to contribute to the efforts of our area. We have been looking at the climate action plan implementation on reducing our waste by redesign, reduction, reuse items, recycling, recovering and disposal, and working together with our public service boards on the climate adaptation agenda and the mitigation of climate change. So looking at our floodplains, etc. And we have a comprehensive document for you to see if you'd like on that.
Jill, that's a really sort of whistle-stop tour around what we know is a very intensive agenda on population health. And because of the importance we place on this, we have a specific population health committee that discharges all aspects of our population health on behalf of the board. Here. We turn now to primary care, and as Abby has said earlier, so much of our investment in managing, talking to, sort of treating patients and service users takes place in primary care. Really important part of our work. So Craig, I'll hand over to you, please.
Okay, thank you, Chair. Most difficult for you to see the infographic, so I'll just pick up some of the key numbers in terms of access to primary care. So from a general medical services, the GP services, we delivered over 2 million consultations in 24-25. In optometry, it was around 128,000 consultations. For dentistry, 193,000 courses of treatment. And in pharmacy, we dispensed 10.8 million items. So that just gives you a bit of the scale of the work that's undertaken in primary care. Looking at specific developments in 24-25, we've started on a journey of looking how we move more services into primary community care. So we've set up a community design group, community by design group. So we're looking at moving we've moved vasectomies, extended minor surgeries, ring pessaries, and complex wounds. We've expanded the provision for homeless patients in Neath Port Talbot with dedicated nurse-led services. And to facilitate the expansion in general medical practices, there were 20 improvement grants with a value of £86,000 with extensions to Pontardawe Health Centre, Brunswick and Cummer. From a pharmacy perspective, we've continued to increase the activity delivered through the National Clinical Community Pharmacy Service. That includes common ailment skills for sore throat tests, emergency hormonal contraception, and emergency medication supplies. Importantly, we've doubled the number of independent prescribers across the patch, and we now have 35 independent prescribers to provide care closer to home. And they're working along general practice to drive the national initiative for 56-day prescribing, so we reduce visits to general practice. In dental, the epidemiology study for the 12-year-olds was published, and that showed an improvement and decrease in prevalence in Swansea Way, which is really positive. And the dental access portal is now open, and we've had 6,500 patients register on there who are waiting for treatment. Waiting for allocation of a dentist. We've successfully implemented changes in endodontics to move patients out of hospital, and similarly, we've got schemes in oral medicine and oral surgery. In optometry, we've successfully implemented national pathways for independent prescribers in 10 practices, and we've implemented the new pathways for medical retina and glaucoma in practices. So we've enabled us to take work out. Next slide. Important piece of work in terms of primary care is the work that the clusters undertake. So that's a combination of the general practitioners, dentists, optometrists, and pharmacists. So there's been a lot of work undertaken in clusters. I'll just pick up a few highlights. In the Bay cluster, we've developed an end-of-life physiotherapy service, focusing on hospital avoidance, reducing length of stay, and supporting patients to remain at home. The Cumtawi cluster, they were the NHS Wales Award winners for a whole system approach to mental health, looking at patients with complex needs, well-being services, and working with the third sector and local authority. In Penderry, there's been a scheme to look at improving health literature, and in the Upper Valleys cluster, sustainability initiative around inhaler recycling, which was the first of its kind in the UK. And finally, in terms of primary care audiology, that's been funded in partnership by all of the 8 clusters, and we're now able to offer community-based wax removal, hearing test, and tinnitus assessments.
Thank you, Craig. And because of the importance the board places on primary care, we have in 25-26 introduced a rolling programme of looking at the different disciplines in primary care at every 4 academy. So we turn now to improve patient safety and quality. And Liz, we have had question from a member of the public around what are we doing to improve complaints management, and how will we weave the role of the Maternity Voices Partnership into our wider work on family and community engagement. So could you pick up those 2 points in part of your presentation, please?
Thank you, Chair. I will absolutely pick up those points, but firstly, I just want to talk about our quality strategy and our quality priorities that we have here in the organisation, and those priorities are refreshed every year. I think the thing that I really want to highlight is what we've done to achieve those priorities and to achieve the improvements that we have. And that's been around our capacity and capability within our teams for improvement. And over the last year, we've trained over 200 staff to really understand how you improve, where you work, and we've held quarterly quality improvement forums. There are many projects underway out there in the organisation, and we're working with the National Safe Care Partnership. We are particularly looking at deconditioning, so that leads to the demographics of our population and how we support people who are in hospital and improve the quality of their recovery. As Abby and Jan have seen this morning, preparation is everything, and keeping that deconditioning to a minimum, and also recognising and responding to deterioration has been something that we've been particularly looking at. Our quality priorities for this last year have been preventing harm from falls, and we've been targeting this work over the last 4 years. And I'm really pleased to be able to say here that the rate of falls per 1,000 bed days is currently 3.4. That's the way that we measure it nationally. And the national average is 6.6. So that improvement methodology and the way that we're implementing that is making a difference to our patients. Pressure damage is another key area for us, and both in hospital and out of hospital we have made significant improvements, and that is again around the improvement methodology that we utilise and how we support our staff to assess what needs to be done to improve. We've built on the work year on year, and when I looked at the figures in June this year, we had a 50% reduction from a year ago in hospital-acquired pressure ulcers. So we know that that's working for us, and that methodology is helping. We've also been nominated for an NHS award around the care that we've done within our communities around pressure ulcer prevention, and that is working within care homes and in people's homes. So we are spreading the improvement work across the whole of the organisation to the population we serve. End of life care was also a priority for us, and we have had many staff now trained in end of life care, and we've continued to promote My Life, My Wishes throughout the organisation, and we are taking part in the national audit around end of life care, which will give us a good baseline of where that's got us to, but also tell us where we need to go further. We've also concentrated on nutrition and hydration, another key part to recovery and to wellness with our population, both in hospital and outside of hospital. Huge amount of work going on around that. The way that we as a board have enhanced how we go and see and how we witness the care that's being given is through our quality assurance processes, and we've undertaken monthly unannounced spot checks, if you like, across the whole of the organisation. We're using a system that helps us to collate what we see and give feedback to those areas. So again, we can support an improvement where required, but also sustainability of the good practice that's happening, and we can celebrate and share that. We've developed our quality dashboard, which gives us openness and transparency around the things that we are measuring to see where we are with quality and quality improvement. I'll come on to complaints and investigations, and that is something that I've taken responsibility for on behalf of the board in the organisation. And it was very clear, not just from some feedback that we had through the independent maternity review and the family-led review that we've received, but also from many of our patients that our response and others, that our responses were not timely and not kind and compassionate. We've already begun to make those changes, both in investigations around complaints, but also investigations around incidents that are reported. We will continue to do that, but we can only do that through engagement with our population and understanding how we do that to the best of our ability. And there will be more to come on that as we go through the coming months. From a maternity voices partnership perspective, we've adopted now the maternity and neonatal voices partnership. So we're mirroring what's happened across NHS England, and we want to strengthen the part that MNVP plays, not only within the organisation, but also helping us to engage externally as well. We've created a perinatal committee, and the MNVP voice is there, the chair is there, and will be part of us developing that committee as we move forward. That was part of our response to the independent review prior to receiving it, but also will help us to respond to the recommendations that have come out of the independent review and the family-led review. With maternity and neonatal services, we were delighted on the 16th of September to reopen the birth centre, and that we are continuing to evaluate care and experience from. We've also strengthened our leadership team within maternity and neonatal services. We've employed a director of maternity who now will report directly to me through the perinatal committee up to board on a regular basis. On receipt of the review, there is much to do, although progress had been recognised, and we're just aligning our response to both that independent review and the family review, and we will be bringing something back to the board in November, but we're setting up a whole transformation around that. We're also, another key area for us around quality and safety is transforming mental health services. We identified mental health and learning disabilities as a priority area for improvement. We have engaged some expert support and advice and developed a programme approach to that. And we know there's a need for urgent short-term improvement and investment in mental health. We will review a longer-term solution as time goes on through our strategy. We'll also need to review the establishments that we have and the staff that we have within mental health to enable us to really appropriately meet the needs of our patients with mental health needs. Looking forward, we want to go back to our quality strategy and develop it in light of our refreshed strategy, which we're launching this afternoon. We also want to look at an integrated structure around governance, clinical governance and corporate governance, so that we can learn from each other and deal with the legislative changes that are coming through putting things right guidance, which is changing. I've already talked about a cultural improvement, but that is key to our successes and will be key to our future success. And I know that Tina, myself, Marie, we're all, as execs, we're working together to look at how we can galvanise that approach across the organisation. And we really want to understand what quality means to our communities. So we'll strengthen our always-on reporting arrangements to make information on the quality of our services accessible and relevant to our patients and communities.
Thank you, Liz. And we covered such a lot of ground there, but anybody who follows the board at each of our meetings, we take a long time to look at different aspects of safety and quality, and members of the public can keep up to date through dipping into our meetings. So Abby referred earlier to the importance of research and development is going to increase in importance for the board. So Richard, would you like to take us through our committee there?
Thank you very much. Just a couple of slides on research development, innovation, and our role as an education institution. It's well known that research active institutions have better outcomes than those who aren't research active. And that's not just about any cutting edge technology or techniques that are used in healthcare institutions that are research active, but there's a halo effect around them, because as a research active institution, you attract people of a high caliber into the roles that you're advertising, and they in turn take their expertise into their day-to-day work and not only into the areas of research. It's important as well to say that in thinking about the research they undertake, that isn't necessarily confined to specialist areas or laboratories. In fact, we've got research programs that go on across primary care through to our most specialist services. And of course, that's undertaken by clinical members of staff of all disciplines, whether they're medics, nurses or allied health scientists. And what that means for us, and then overlooking the past 12 months, is we undertook 372 studies in the health, which meant that 3,332 people got to benefit from the expertise that they received and participating in studies. And those studies will have ranged from studies in which they participated and were asked questions, through to studies in which they were the beneficiaries of new treatments or novel technologies. We've got a similar amount of activity ongoing this year, and we're leading a number of studies across the UK where we're the principal investigating site. And of course, the other effect that has for the health board, which is really important, is that this generates income for us, particularly when the research has a commercial angle, when there's pharmaceutical companies and other bodies fund us in order to undertake that research. And that was to the tune of £2.4 million last year. Next slide, please. And being a university health board doesn't just mean research. We're obviously closely involved, as Abby alluded to, in the education and the training of the next generations of healthcare workers. And just some numbers up there again in terms of the number and breadth of individuals who've benefited from gaining clinical experience with us. 645 doctors in training, 150 GP trainees, 250 specialist trainees, with 567 medical students. And the activity that we delivered for them equates to over 1,500 weeks of teaching during the year. Nearly 1,200 nursing students, plus students across allied health sciences, midwifery and pharmacy. And of course, what we aim to do for these students and the training grade staff who work with us is to provide them with the best possible teaching experience, not only so they get the best out of their time with us, but also recognising it's an opportunity for us to harness that talent and to look for them to look to us as their permanent home for the future when they're seeking them. Thank you very much.
Thank you, Richard. And now we move to some very important service areas, and I'm going to turn to Craig again to take us through unscheduled care.
Thank you, Chair. Next slide, please. It's the right order. Okay. So the infographic, which you can see in front of you, there's a little bit of heat map over the last 12 or 18 months in terms of our national reporting status. So level 4 being in red, level 3 in sort of amber, yellow, and 2 is represented yellow. So you can see on a week-on-week basis how we've improved in terms of the that high level of status over this period. So how have we achieved that? Well, it's been a whole system approach with secondary care, primary care, community and local authority partners. We've particularly focused on frailty and merging of our virtual wards, ACT and older persons services, and got those under the broader older persons service with the clinical lead. We've got the provision of senior decision makers now at the front door around the emergency department, acute medical unit and same day emergency care facility. And we've right-sized our clinical cover as part of a change to the acute medical rota. At the other end of the pathway, as Abby alluded to, we've seen huge improvements in terms of tackling our package of care delayed, working with the local authority and primary care and community. And we've also reconfigured ED include from a process and operational perspective, but also capital and estates perspective. And all of those things were brought to our attention by the ED staff who came to the board in January. So what does that mean? So despite the increase in ambulance attendances, because we've seen a 9% increase over the last 12 months, we're having over 50 a day. Ambulance handovers now have reduced from the number of the past 45 minutes pre was 18 per day. We've seen 155% improvement on that. The average time for handover has moved from 2 hours 43 to now to 29 minutes. And we've had a 16% increase in weekly discharge levels. But obviously, it's not just about the matrix, it's about the improvement that that's made then to patient care, safety and experience, but also an improvement to the staff well-being as well and the environment that they are working in. Next slide. In terms of planned care, as was alluded to earlier on, we've made great strides. The centralisation of the emergency service allowed us to have a dedicated planned care facility in Neath Port Talbot, and we've met the target in 2025, not only for a number of patients reaching 52 weeks for an outpatient appointment, but also 104 weeks for treatment. And we've maintained on that trajectory. We continue to drive down outpatients this year and also reduce cataract rates. And also be remiss me of not mentioning as well that we've achieved the therapy standards, radiology reporting standards of 8 weeks and 14 weeks respectively. And we've seen significant improvements around endoscopy. From next slide, please. From a cancer performance perspective, this still remains a challenge for us as an organisation. Throughout the year, we did hit the 60% target, which is required for de-escalation for targeted intervention, but we've still not done that consistently enough. And we've still seen a few dips over the last months. We now seem to be back on a recovery trajectory. Some of the particular challenges you'll see there from the infographics is around urology and around lower GI, and they are primarily due to treatment capacity in those areas. Our focus very much during 24-25 has been on first appointment within 10 days and decision to treat within 31 days. So there's more work to be done around the treatment element in this area. Thank you.
Thank you very much, Craig. And anyone can follow in detail the way in which the board and its performance and finance committee oversees progress against each of these important service areas are on our website and can be found in the papers for each of our meetings. We touched on digital data earlier, so Matt, your opportunity now to take us through the importance that the board places on the whole digital agenda.
Thank you, Chair. I'm Das Matthew John, Director of Digital for the Health Board. The slide you see before you represents the Health Board's new digital strategy that we approved in March this year, and it really sets out our vision. And our vision is to improve the health and well-being of the population of Swansea Bay by harnessing the power of digital technology and digital transformation. Two important terms there. The technology, yes, technology is complex, and we've got a lot of work to take forward the solutions that we need across the organisation, working with partners. But digital transformation is arguably the harder part of this, and that is the business change that we need to engender right across the organisation, taking our people with us on that journey. And that's our staff. And then, of course, there's the patients and population that we need to engage with and ensure that together we are working on getting the best out of digital as we take the health board forward. Because our ambition is to be a digital first organisation, supporting our clinicians and our wider staff groups to be more effective and efficient in order to release more time to care, and supporting our patients and the population, providing better access to online services and information, empowering patients to have a better understanding and control, therefore, of their health matters. So we've got some good examples already of delivery in 24-25. I guess I'll pick up on our two flagship projects. First of all, electronic prescribing and medicines administration across inpatient settings. Following on from successful implementations in the acute wards, we rolled out the solution to mental health and learning disabilities. So we now have, across all wards, across the organisation, safe ways of prescribing medication and administrating medication, which has made a huge difference. And the second project is around the patient portal provision that we have for our population. We've now coupled the opportunity of the NHS Wales app, which is in its infancy in providing key primary care information, with our existing Swansea Bay patient portal functionality, which provides blood test results and secondary care clinical documents and letters. And together, we now have a great offering as a health board to all of our population. And already we've seen 20,000 of our patients take up on that. And the numbers are increasing by about 1,000 per week as we move forward in this financial year. Another key area for us, of course, is cybersecurity and making sure that all we do in the digital space is safe. That requires huge infrastructure projects that we take across the organisation, and we're currently replacing the networks that we have in all of our hospital sites. This year, 25-26, has a number of large implementations that we are taking forward. We've mentioned the mental health transformation programme already. We will implement our first phase digital solution using the Rio system, working closely with Swansea Council and Newport Talbot Council. So we have integrated information across health and social care. Digital maternity is another key space for us. We've already talked about our improvements in our maternity service, and we need to support that with the best digital solution that we can. And we will have the Badgernet maternity system in place by March 2026. We are replacing our large diagnostic systems this year, radiology and pathology, big projects that are happening across Wales, and they will take significant effort in the health board, but will put us in a better place in how we provide those key services. And finally, ophthalmology. We've gone live yesterday with the first phase of our Open Eyes product, which is now enabling the key information for ophthalmology patients to be captured digitally rather than on paper. So they're the key projects we're taking forward this year. We're really interested in how we take forward the opportunity of artificial intelligence. We've got some great examples of clinical uses of that already being piloted, and using products like Microsoft Copilot, our workforce-wide efforts to modernize, to make ourselves more efficient, are starting to happen, with more and more adoption of these key tools happening across the organization. So the key to success for us moving forward is going to be co-production with our clinical leads across the organization. This isn't digital for the sake of digital. This is digital to support us to be as best as we can to provide that support to our clinical leads, to give them the opportunity to deliver the best care to patients. We need to work with regional and national partners so that we've got a consistent and seamless digital offering for our patients as they use services that cross South West Wales boundaries and beyond. And then most importantly, that we engage and provide and get feedback from our population. And that's essential in order that we build confidence and get it right to the patients that we serve.
Thank you. Diolch, Matt. I mentioned at the start that we have 12,800 whole-time equivalent staff. That's 14,700 in the headcount. And everything we do depends on having the right staff in the right place at the right time. So I'm going to hand over to Tina Ricketts now to actually take us through what makes Swansea Bay a great place to work.
Thank you. Board Tina Ricketts, Director of Workforce and Organisational Development for the Health Board. I have got an infographics to share with you around the composition of the workforce in numbers. This is by head count. I thought it might be of interest to the people to see that we have got 77% of our workforce being female. We've got 41% being part-time, which is higher than other health boards, interestingly. Usually about a third of part-timers. So we're above that, showing our approach to flexible working. And 73.6% of our staff provide clinical services. That's a ratio of 7.3 to 1 non-clinical role. And we have got 20% of our workforce over 55 in age and 16% under 30 years of age. We've got a mixture of people just joining the organisation, so 21% in the last 2 years, with over 16% in the having 20 years plus service. And through our international recruitment, we've now got 12% of our workforce being from a global majority background. So quite a diverse workforce, and really important to me that that diversity shines through, because if we have that diversity in the workforce, we then better understand the needs of our diverse population. Moving on to the next slide, please, around the people strategy. So this was presented to the AGM last year, so it's been in place since January 2024. It's got 7 aims there. I'll just draw out some highlights of what we focused on for last year, and then areas that we still need to work on for this year. So last year we focused around making sure we have the right health and wellbeing offer in place for our staff. We still, as a health board, has got the highest sickness absence rate with our workforce across the health boards in Wales. So our offers are really important that we've got the right support in place and occupational health services. We've also really focused on attracting and retaining staff, and we've made real inroads in the last year in this space. So our turnover rate's gone down by 2% in the year. And we've also reduced our vacancy rate substantially by looking at all of our recruitment campaigns. We've also focused on making sure we've got the right e-rostering systems, and Richard has been done a lot of work around job planning for our medical staff. We're now up to 95% compliance for those. We've also spent time on making sure education offer that Richard touched on is fit for purpose, and we've been assessed by HEIW as being making improvements in those areas. And we've also introduced some what we call brilliant basics for line managers to make sure they've got the fundamental skills to support our staff. So the areas that we still need to work on for this year are staff engagement. So we're getting feedback from our staff survey, the high sickness absence rates. There's indicators that we're not getting that right across our organisation, so that will be a focus. We also need to make sure that we're planning our workforce better, so we're less reliant on the temporary workforce. To Matt's presentation, need to make sure we've got the right digital skills for our workforce, and we also need to make sure we continue to improve on our quality, diversity and inclusion, so everybody can be themselves at work, and we recognise the talent in each and every member of staff. So hopefully that's a helpful overview of the workforce. Happy to take questions.
Thank you. We'll see if there are any questions come in, Tina, from our members of the public online. Thank you. So we are responsible for the effective financial stewardship of public money that we've already touched on today. And I'm going to ask Darren to take us through how we discharge that stewardship role.
Thank you, Chair. I'm Darren. Good afternoon. I'm Darren Griffiths. I'm the Director of Finance and Performance for the Health Board. Next slide, please. The slide shows that we have 4 financial duties, and I'll just cover each of these before going into them in detail. So the first financial duty is to ensure that our revenue expenditure, which is the money we spend on staff, consumables, drugs, etc., does not exceed the money we get over a 3-year period. The second duty is similar. This relates to the capital spend, and the capital spend is money we spend on our buildings, medical equipment, and Matt's IT kit. And again, we need to make sure that we don't exceed the allocation that we get for that 3 years. The third target is more of a global target, but it's couched under the financial duties, and that is we have a duty to prepare a 3-year integrated medium-term plan. And the final duty is very specific to finance, which is we must pay 95% of our non-NHS invoices. That's by number rather than value within 30 days of delivery. And each of the slides which follows now will take us through these. So if we could move to the next one, please. This slide shows that in terms of the revenue position, we reported a deficit of 42.5 million in 2024-25. There's year 3 on there. And whilst that figure was better than we'd forecast in the total set of us, it clearly represents a significant deficit for the health board, and is 3% of our total direct allocation for that year. And if you look across the previous years, you can see that in 2023-24, we reported a deficit of 16.8 million. But that in the first year of this 3-year period, we reported a financial surplus of 1.8 million. So in terms of the totality of those 3 years, in aggregate terms, we reported a 3-year deficit of 57 million against the 3.8 billion spent. Or failed the revenue duty for the board. Next slide, please. In terms of capital, the numbers are slightly smaller, so we're in millions rather than billions on this slide. And in 2024-25, as a board, we reported a £61,000 surplus on capital, and that's against a £54 million spend in year. And that was on the diagnostic equipment, some hospital infrastructure improvements, medical equipment, digital. And you can see again in the similar presentation to the previous slide, in 2 previous years, we reported very modest surpluses of 55,000 in 23-24 and 38,000 in 22-23, which means across the 3 years of this particular target, we reported a surplus of 154,000, which means we met the duty in terms of our capital resource limit. Next slide, please. There are 2 slides on the integrated medium-term plan. But due to the financial challenges we had during that period, we were unable to describe a trajectory for 3 years, which got us to balance. And therefore, as a board, we were unable to prepare an integrated medium-term plan that gives that financial balance. And whilst we do look forward over 3 years and try to plan our services on a longer term than an annual basis, we find ourselves now in an annual planning cycle, which means that we'd be unable to develop an integrated medium-term plan for the year in question, 24-25. For this financial year, we've also been to do that. I think it's the slide after next, please. That one, yes, thank you. And from an invoice payment perspective, you can see the years are the other way around on the slide. For 24-25, we paid 297,000 invoices finance, and 282,000 of those were paid at the target. So we achieved the 95% target. As we did the year before, we were marginally off the year prior to that. So in that sense, we've met that duty as well. I just wanted to come out of the targets and just set a bit of scene around some of our expenditure levels. So if we could turn to the next slide, please, because this gives you a sense of the scale of the organisation. We spend over £4.5 million a day in Swansea Bay Health Board, and this year we'll spend in excess of 1.8 billion on delivering services for our population. And back to 24-25, and just comparing some things to previous years, you can see at the top there our staff bill paid the 14,700 headcount that Tina's described. Increased by 11.9% in year. Half of that was the wage award for staff. We had 6% and a 5% wage award last year for different staff groups. And organisations increased their pension contributions for staff as well by 3%. The rest is growth. So a significant increase in the pay bill, and we spent 882 million on staff last year. From a medicines perspective, and Craig's told us that we dispensed 10.8 million prescriptions last year. That cost £85 million. And that was only £1 million more than the previous year. But you can see beneath that, our hospital-based drugs or secondary care drugs, the spend there increased from 85 million in the previous year to 96 million in the last full financial year. So a substantial increase of 13% in our prescribing there. And a lot of that's driven by very specialist drugs that are enabling our patients to survive longer and have healthier, longer lives. And that's a trend I'd expect to see continue. From a continuing healthcare perspective, you can see there again a large jump from 23-24 to 22-25 of 16%. Prior to that, it was a jump of 19 million as well. So our continuing healthcare bill has gone from 60 million 2 years ago to 92 million last year. We anticipate that being about 100 million this year. So again, growth in that spend area outside of the hospital setting. I think importantly, just a word of hope, because these are incredibly challenging times in terms of our financial position. We've worked hard this year to deliver a plan which starts our recovery. Our projections for this year are higher than last year. We're projecting a higher deficit, but for the subsequent years, we're projecting a recovery through that. And the board this week on Thursday will receive the first cut of our plan to give confidence of delivery of that and to take us into future strategic discussions. And I thought, by way of sharing some of the aspects of the key things we're going to look at from now on in, because at the moment, we're just trying to get the cost of running this organisation down in a sensible and structured way. Each year, we can look to service transformation, to look at how we configure our services across our 3 acute sites, how we move more resource to health promotion, population health, primary care, community services out of the hospital centre, so more to prevention away from treatment. To look at how we work with our neighbouring health boards for opportunities across our boundaries, and to look particularly at how we interact with other health boards through some of the contractual mechanisms. So there's lots of positive things that we can go for if we improve care delivery, improve quality, and be more cost effective in future. And this year, building on the foundations of 2025 is a pivotal year in the journey in terms of our resource allocation and how we spend our money. Thank you.
We had some questions in around the impact of the level of savings. So we'll pick those up at the end. Abby, you and Jill might want to comment on them as we get to that point. We'll turn now to our charity, for which we're very proud, and which is going from Spain. So I'm going to get Richard to take us through that.
Thank you, Chair. You've stolen my thunder there, because that's exactly what I was going to say, actually, was it's going from strength to strength, building on solid foundations. The year before last, 23-24, we put in place some important building blocks and foundations for the charity, and we've certainly built on that in the year 24 to 25 and since then as well. So we can go on to the next slide, please. So just to give a reminder, first of all, about why the charity exists and what it does. So it raises money for pioneering research, cutting-edge equipment, enhancing buildings and spaces, patient and family well-being, and staff well-being and training. But it also does that through engagement, and I think that's really, really important, because the engagement's with staff and it's also with patients, and there's patients whether they're past, present and future, and it often brings those staff and patients together as well. So some of the things that we've been doing over the last year or so, we've built a brand new website for the charity, which is there to raise its profile. In parallel with that, we've undertaken a lot more social media activity to raise the profile of the charity. But we've also focused on some distinct appeals, so really focusing on what's important to individuals. So a couple of examples there being the Going the Extra Mile for Cancer appeal and the Cwtch Close appeal Cwtch Close. Both of those really big and high profile campaigns and appeals that are intended to up that engagement, as I said. We've also focused on major events, and there's just a couple of examples there. The photo at the top of the rugby, that's an all-women's touch rugby tournament that took place earlier this summer. So that involves 16 teams, and through that we raised over £23,000. But actually, it's not just about the money raised. Again, it's about getting the message out there about what we're trying to do. And then we've got Jiffy's Cancer 50 Challenge. So that's the bike ride from Cardiff to Mangles, with 330 riders taking part in that this year. So that shows the impact of that. And we're very grateful to Jonathan Davis for supporting the campaign in conjunction with Alindra there. If I can go on to the next slide, please. So the next slide shows the Cwtch Close appeal. So this was in order to fund the refurbishment of the 5 houses that we have in Singleton. The houses support the families of babies in our neonatal intensive care unit, providing much needed respite for those individuals during some particularly tough times. We're very, very grateful to Mal Pope for the support that he's provided this year and last, and also to Swansea City, who made the Cwtch Close appeal their charity of the season. Without their support, we wouldn't have achieved what we've been able to do. And we have now named 2 of the houses and also moved on to the refurbishment as well. And as you can see there from the graphic, 91% of the total is raised. And then if I can go on to my final slide, please. So this is the next big appeal that we've got running, and it's about raising £200,000 to transform the outdated garden at the Neath Talbot Children's Centre, and it's to turn it into a safe, sensory rich outdoor therapy space for the children and young people with additional needs. So another big worthwhile charity appeal there to get behind, and I think it's indicative of the progress that the charity's been making. Thank you, Chair.
Thank you, Richard. That's a very uplifting synopsis of the work of the charity. You've heard us talk today about what we're doing in 2025-26. So I'm going to ask you to pull that together for a formally, so that we know what we're coming back to with at this time next year.
I'm Steve Spill. I'm the Vice Chair of the Health Board, it's the nature of AGMs that you look back at a point in history. And these slides are entitled "A Look Forward to 25-26," but of course we're almost halfway through that year already. So the bullet points that I'll be describing over the next minute or so are very much work in progress rather than something we're going to do in the future. And so the first one there, developing a population health focus in all that we do. This is front of my mind at the moment because we had a population health committee meeting just this morning. We dealt with some pretty meaty issues such as cancer mortality in Swansea Bay. I'll give you a clue, it's too high. And vaccination equity and take-up in Swansea Bay, I'll give you a clue, it's too low. And diabetes treatment, it's going very well, but funding is a challenge. And the reason that these, when we take these papers, they're important is because these will inform the way the Health Board prepares its services in the future. And one of the important things we heard today was that each service group, as we go forward, will be measured and will measure themselves not just on what they do to keep sick people or to make sick people better. Excuse me, I'm choking. But what they do to prevent that sickness in the first place. And all of this overseen by the Population Health Committee of the board. And the second piece of work that's going on is improving access for our patients to the treatment they need, be it in emergency care, waiting for appointments, test treatments, operations, etc. But I would add to that what we heard from Craig earlier, access to primary care, GPs and dentistry, which it's in primary care that most of our population meets the NHS. And we've heard about the transformation programs for the services to maternity and neonatal care and mental health services. These are moving at pace. The mental health transformation program, there'll be a paper presented to the board in the next couple of meetings, in the next couple of months, I should say. And that will be a big change to the way we present those services. I think we have to move to the next slide. Yeah. We've heard a bit about from Tina about workforce, and it's crucial. We are the biggest employer in the area, and it's crucial that our staff enjoy their work and come to work feeling good about their jobs. Not only because we have that responsibility as a major employer, but also because if they're happy at work, then they do a better job, and our patients get better care. So everybody wins. And that work overseen by the Workforce and Organisational Development Committee is very important. Renewing the organisation, focusing on improved delivery and outcomes, something which the Performance and Finance Committee oversees on a regular basis, is crucial. We'll hear more about that in the next slide. And then finally, making sure that everything that we do is financially sustainable. We just heard from Darren about the challenges we have in that area. We need to spend every penny of money, public money, wisely. Not only because it's our financial duty, but if we reduce waste, if we make savings, then we'll have more money to spend on improving our services and doing our job in an even more productive way. So those are just some of the key highlights of what we're doing. As we heard, there are 14,000 people out there today working extremely hard on the services that we provide. And these are the highlights around which we are all coalescing. Stop there.
Thank you, Steve. And as I've said, we will be back again this time next year to explain how we got on with that raft of ambitious work we have underway. And Abby, that leads us nicely into the organisational strategy, which will underpin this work from now on. Over to you.
Indeed, it will. Thank you very much, Dan. And I'm really pleased, as I said at the beginning of the meeting, to introduce and launch our organisational strategy. Coming into the organisation, colleagues, both internal and external, shared reflections that perhaps we weren't sharp enough in terms of of a kind of high level overview of the organisation strategy, what we're here to achieve for our populations and communities and the colleagues that work in the organisation. So under the leadership of Marie Davis, our new Director of Planning and Partnerships, we've refreshed the strategy. So it doesn't contain anything new, but it articulates in a crisper and sharper way in terms of what it is we're trying to deliver for our population, what we're aspiring to achieve. Next slide, please. So we have built on, next slide again, the vision that was previously set out in the last 10-year strategy for the organisation around really being focused and targeting our efforts to improving health outcomes for our population. And as you can see there, what we're describing that as being a healthier future for everyone in our communities where people live well and age well. And that's about longer, healthier, happier lives. It's about supporting people to be active and independent for as long as possible. And it's about ensuring people can access high quality care when they most need it in their lives. Next slide, please. We've done some work to sharpen up what that means in terms of our vision, mission, sorry. So this is about any member of our organisation being able to describe what is it here we're to do as an organisation. And again, we've picked this up from the last organisational strategy, our mission being around better health, better care and better lives as a consequence of that. I'm not going to go through the bullet points here, they're small on the screen, but the detail below sets out what we mean by those statements. They're easy to say, more difficult to deliver and evidence, but what we describe there is what we mean by those things and how it is important that we collaborate with partners to achieve that, because we know that many of the things that contribute to our health and well-being are things that actually happen outside direct healthcare provision. So have we got a safe and warm house above our heads? Have we got access to good education? Have we got fair, paid and meaningful jobs for people to access, and et cetera, et cetera. So working in partnership, as described in the wellbeing of future generation being absolutely critical to our success in this. Next slide, please. So why are we doing this? The next two slides, this is the Welsh and the next slide is the English, describe some of the key headlines. Jill's alluded to some of this in terms of the presentation she gave earlier on, in terms of the key characteristics in our the communities that we need to address. So some of these are really quite shocking in today's society, that we have 1 in 6 of our children who are not up to date on our vaccinations. We know that is a really simple population public health intervention that works, and yet some of our children are not accessing, and we need to work hard to ensure that we can enable access for those children to get the benefit of that highly successful intervention. We touched upon health inequity before in terms of life expectancy and the gap in healthy age life lived. And again, this being really important in terms of how people report on their health and well-being. And again, some of the data in here describes that. We talk about this through the life stages, so making sure that every child has a good start in life. So some of the work that we're doing under the perinatal work will be about how we ensure that in the preconception and during pregnancy, we're supporting women to be healthy, and supporting newborns and families to give the best children a start in life, recognising that 1 in 5 of our children are living in poverty, which is a real challenge to those families. This also describes some of the healthy behaviours, or perhaps unhealthy behaviours I should describe, in our population. These are all things that have been improving, but there is not necessarily an equal equity or distribution in our population. So some of our more deprived communities will see higher levels of smoking, for example. And again, Jan and I visiting cancer rehabilitation this morning, we saw that really coming through in the evidence around people who are smoking and the impact that's having on their health. Next slide, please. So that's the driver. That is what is behind why we want to refresh the strategy and ensure that all our enabling strategic documents, like the population health plan, are aligned to delivering the goals we set out in the strategy. I'm not going to talk through this, but this is a kind of infographics of how many patients and at what points in pathways and where they're accessing services. And again, we've touched upon many of these things already in terms of how many people we are providing support to through the provision of high quality healthcare. Next slide, please. So turning to some of the ways that we operate, Jill's touched upon it in terms of the slide she had on sustainability, the importance of us as a big employer, as Tina mentioned, the importance of us in terms of our responsibility to the environment and the local economy, the importance of making sure that we spend every pound that we've got in things like goods and services, that we're driving the very best we can from a kind of foundational economy perspective in terms of getting best value for the investments we're making locally for our population. And we describe those as ways of working and the pillars that sort of underpin the ways of working. Again, not new, but articulating them very explicitly in this strategy refresh. Next slide, please. So one of the things that is really important to us and we reflect on every day is about the values and the standards that we're holding ourselves to account. Values haven't changed. They were developed a number of years back now, but with our staff and team colleagues across the organisation. So what is important to us in terms of how we go about our business day in, day out? And again, we're refreshing and describing in the strategy what that looks like in terms of the behaviours that we expect from one another and how we'll hold one another to account in our day-to-day working to ensure that we uphold these values. And the One Bay Way was a really good programme of engagement where we listened to colleagues both externally and internally around standards we want to apply in terms of how we go about our business. And again, those are set out in the strategy, really about the culture we want to create that will enable us to be a really high-performing organisation that delivers the very best outcomes for our patients. A couple more slides relate to the overarching strategic objectives. Move on to the next one, please. The first objective is about better health for all. And again, we've described in here the particular area of focus that we want to give. A strategy by its nature isn't necessarily about describing everything we do, but it's about identifying and discerning the most important priorities that are going to give us the best return in terms of the efforts and resource we put into them. So we're putting health and the population health front and centre stage as our first strategic objective. Second one, next slide, is around improving patient safety. And Liz has already talked about why this is so important for our patients. And again, timeliness, effectiveness, safe care, making sure people can access care when they need it. And things like looking at avoidable harm. We can't remove all risk from harm, but we're looking at the things that we can do to reduce unwarranted variation. And of course, mortality rates is a really important and a key focus in terms of a key metric about how well we are supporting patients at key points in their care journey. Next slide, please. On the third strategic objectives around care and partnership, the way Craig articulated the operational delivery is very much centred around this. So we know we want to do more close to home, digitally enabled, as Matt talked about. And this is really about making sure we deliver the right care in the right places. And we do have challenges around our estate, and that will be an important part. One of our key enabling strategic plans is around our 10-year estate strategy and making sure it's refreshed and aligned as we develop both this strategy and our clinical services plan, which performs an important component of this. Fourth strategic objective on the next slide is about being a great place to work. And again, I'm not going to dwell on this. Tina's had to leave for another appointment, but I think we've described this really well. We want to be a place where colleagues come and work with us, stay with us, and that we can enable staff to flourish and develop their careers and develop their leadership roles, and to make sure one of the key things that we can judge our success on is how well staff feel engaged. And so things like the staff survey being a really important way that we can reflect this. Tina touched upon the importance of reflecting diversity, making sure people right across the spectrum can see themselves reflected in work, and that we think about the global majority in particular being represented effectively right through the structures of our organisation, which is work in progress. We know we've got more work to do in that respect. And the final strategic objective is about how we use our totality of our resources, so being resilient, sustainable and responsible organisations. So really thinking about our financial sustainability, our environmental sustainability, and having a suite of actions that enable us to do that. I talk about the suite of actions. What was really important when we refreshed is we know how far we need to travel and how we will judge ourselves in terms of being successful in terms of the strategy. And the next suite of slides, I think, are in here, or maybe they're in the detail of the document. They're in the detail of the document, which talk about what's our baseline. So what are we doing in 24, 25? And by the time we get to the end of the 10-year period, what are the big dials? What are the big metrics that we are wanting to shift and change? And you'll see that in the document that's being launched and published and will be uploaded on our strategy. And our intention is to make sure that this will be like a golden thread through the organisation. So when our team colleagues are having their annual appraisal and objectives, the conversation will be around how are your objectives contributing towards the delivery of our strategic objectives, so people can see as part of the team of 14,500 people that we've got, that they're all making a contribution and they can see how they connect to that. And then this final slide is describing the complexity that sits underneath the organisational strategy. We've talked about a number of the enabling strategies we got at the moment that sit there. They're in different time frames. So some are coming to be refreshed shortly, and they'll be refreshed in the context of the overarching strategy. And some have only recently been published. So the job of the work that we're doing around how we're delivering against the strategy and the governance we've got around this will make sure all of those things align as we progress through the strategy, and that we take stock at key points along the journey at sort of 3-year cycles as we develop our INTP to ensure that we're on track in making the progress. Some of these are really stretching. We are ambitious for our population and our communities. We probably won't get to all of the outcomes we want to achieve, but we've got to aim high, and we've got to keep revisiting and do a mid-year review to see where we're on track and where we're off track, and how we need to adapt and change to the changing technology that we've heard about, and things that will come forward that we're not even aware of at the moment, new treatments that may well change the course of action. If you think about some of the things we're doing in cancer care, that could have a radical impact on outcomes. And of course, we need to do this and cognizant of the fact that we're working closely with Hal VAR. So the clinical services plan, which is the green chunk on the diagram, we will very much be doing in partnership with Hal VAR and our collaboration with Hal VAR, and within Cardiff and Vale University Health Board, who are partners with us in terms of the tertiary and specialist services that we provide right across the whole of the South Wales population. I think that's the last slide. Just saying, really grateful to colleagues who've been involved in pulling this together, and being very patient with us as we took this through the board and did wordsmithing and had different views about how you articulate this. And I hope you feel that when you see the document published on the website, and we're trying to make it as interactive as possible and add more in as we develop the strategy, that we have struck the right balance in terms of how we describe this in a way that's accessible to both our team colleagues, our stakeholders, both within and out with of the organisation, and most importantly to the communities that we're here to serve day in, day out. Thank you very much indeed.
Thank you, Abby, and that's a really exciting refresh of our strategy, and we look forward to coming back next year to update you on it. We've now reached the section in our agenda on Q&A, and we've had 5 questions in, 3 of which are on the same subject, so we'll take those together. Now, we won't have any more time for additional questions, but as ever, please email us outside of the AGM if anyone thinks of another question they want to ask. Our first question, and we will supply a written answer to this that we can give more detail on. But Liz, can you just give an initial response to this question, please? What plans do you have in place to provide a better and more satisfactory hospital admission experience for those adults with learning disabilities who come to hospital via ED in Morrison? And this is particularly around the experience of being admitted out of hours and weekends, when we understand the experience can be poor and distressing. As I said, we'll provide a longer response, but could you just answer initially?
Yeah, thank you, Chair. I think this is an area that we need to focus on, because if we get that emergency admission right for those with particular needs into whatever those needs are from a diversity perspective and the quality perspective, then we get it right for most people. So I would say we need to absolutely harness the expertise that we have in the organisation to help us to look and focus on this particularly. It will be very daunting for anybody coming into ED, those with specific needs even more. I think we need to engage with our population, and we will have process of engagement going forward. We're just mapping that out now. But I would particularly want to use those with lived experience, those who have come into our services, but also the organisations that support individuals with learning disabilities, and start to really engage not only in how we can enhance experience, make it less daunting and scary for somebody, but also how we can listen to those who have absolute understanding of the needs of those individuals. And I think we can take it even broader than that, but let's start with that. I would love to see us giving opportunities to those with learning disabilities in our organisation in many, many more ways, so that we can become more familiar with understanding that need. So work to do, Jan, but we will.
Thank you, Liz, and we will follow up with a formal written report. Now we have 3 questions, they're all interlinked, so we're going to take them together. How are you going to make sure changes of the services do not make things worse for people, especially those with little money who will have to travel further? How radical will the changes you need to make to balance finances to provide sustainable services have to be? How will you make sure that the most disadvantaged of the population are not disproportionately affected? And then how will the Health Board make sure that savings do not have an impact on the population we serve? And these questions are those that the board asks themselves, of course. So Abby, I'm going to start and ask you to answer, and then Darren and Jill, if you want to add in.
Thank you. Yeah, thank you very much, Jan, and as you say, questions that we have been discussing as well. So a number of comments in response to the questions. Firstly, the programme of work that we've got to underpin the financial plan for this year has a number of components to it. So some of that is about really enabling us to reduce some of the expenditure that is unwarranted and variable. So if we think about where we're an outlier, Tina talked earlier about sickness absence. We have the highest sickness absence rate. And what that's driving is it's driving expenditure in variable pay that is costing us a significant amount of money. So that is one example where it's the right thing to do to get people back to work and enable people come back to work. We might need to be more flexible and really using our occupational health service to ensure that we can bring people back to work, obviously when they are well, and supporting people to remain in work. And that enables us to bring down some of those costs. We have been successful in terms of recruiting staff in. So in a number of areas, we're actually over establishment, which is a really strong place to be in. So overseas recruitment, taking nurses coming off and midwives off the training programs and some of the other clinical training programs. So we have the ability to hold some of those vacancies. I know there's a subsequent question, Jana, in relation to that. But that enables us to utilise our workforce differently and to think about where we've got pressures in the system. And it does enable us to hold some of our vacancies for a short period of time while we go through this transition. And the other piece of work, which is around organising for success, making sure we've got the right structures in our services and making sure that the managers, as Tina was describing, have got the tools and techniques that they need to manage their staff rotas, their budgets and their kind of workforce planning and making sure that those things are all in place. There's then a bit about which is transforming the way that we deliver services. So some of that will be really thinking about how and where we deliver our services, and it's the balance. So what Craig described is we are making some significant progress in what we're delivering out in our local communities. And what we need to make sure is that when people do need to come hospital, that's a really timely intervention. They're there for the minimum amount of time, whether that's an inpatient admission, whether that's surgery, or whether that's outpatient, and we're making best use of people's time. I think it's a really good currency, not to think about our own time and our staff time, but about patients' time and not waiting excessively, not deteriorating, sitting on waiting list, not being called back for a follow-up outpatient appointment that they don't actually need, because we're doing a lot of work on patient-initiated follow-ups. And we know those things can help us in terms of where we spend our money and where our financial resources will be. And then I think there's some bigger discussions that we'll need to have as part of this plan, which will take us into years 2 and 3. And some of those things are things that are driving our costs underneath. So if you think about where we distribute our services, we've got mental health services on multiple sites. That's very difficult from a staffing point of view, from a safety point of view. As Liz touched upon, we are working through how we might come to an interim and then a longer term solution that we bring services together. With any change that we make, we need to make sure that our quality impact assessment and our equality impact assessments are done so that we can make sure there are no unintended consequences we've not thought about. And that's always a balance, and that will help us to be really cognizant about, are there any particular groups from the protected characteristic groups that would be disadvantaged particularly? And we've also got the socioeconomic duty around making sure our decisions are taken in the context of that as well. And it's about engaging with patients. So we do know that in terms of things like planned care, the question about if we can get more timely access, is there a question about would you travel, could you travel? But that certainly needs to be part of the conversation about can you access travel and transport. And when you think about that deprivation, I suspect many of us will have come here in a car, just remembering how many of our communities do not have access to travel and rely on public transport. And those of our staff and colleagues who know trying to get around our patch in transport doesn't always join up for people. So, John, that's a really important message for us in terms of how do we work with local authorities to make our transport plans join up to our sites, but also that when we are working with the ambulance trust who provides a non-emergency patient transport, all those things are planned in as we make changes to the way we deliver services.
Thank you. And Phil, did you want to add anything there? Because we do have impact assessment tools that we can use, can't we? Just to make sure that we are not following the money at the expense of safety and quality.
Yeah, absolutely. We should be using our health equality impact assessments for all new services and developments. And also the monitoring of the population health indicators that's happening throughout the organisation and will increase throughout to a service level as well. And in time, we can include in those health inequities so that, for instance, we'll be able to look at the staging of cancer diagnoses to make sure that those living in our more deprived communities, that they are not being diagnosed much later than those in more affluent communities, and also for our inclusion health groups. Also that the cardiovascular indicators that we'll be able to monitor, who is accessing those early diagnostics. So looking at, those that are diagnosed with narrowing of the heart arteries or high blood pressure with kidney involvement and damage, that those diagnostics are on an equivalent basis for all, but also monitoring that how much disease would we expect to see actually in some of our populations. So in some of our more deprived areas, we'd expect to see more. So do the referrals actually reflect that? We've actually asked for help from Public Health Wales on this as well, because a few years ago they did a really good piece of work on burden of disease, which encompasses these aspects. So we're hopeful that we can, finesse and enhance that sort of population health lens through the organisation.
Thank you, Jo. And Darren, from a sort of strategic financial leadership perspective, is there anything that you'd like to?
Just briefly to add, Chair, conscious of time, I think Abby's touched on this. Strong, clear plans, but what we're going to do informed by some of the data that Jo has just described, key strategically. We're going to spend 1.8 billion this year. Is every pound of that working as hard as it could be? Probably not, and we've got opportunity to look at that. But I was going to make the point as well that quality care often really always costs less. So lower infections, better flows through hospital and patients aren't blocked in beds, presenteeism in work, all of this is good for our patient staff and actually drive a more cost-effective organisation as well. So I think there's the strategic landscape of resource deployment, pursuit of quality, and then yes, into that there will be some hard yards along your traditional savings routes, but there are really good things to go at as well that you get us to where we need to be.
And our final question, along the same lines, but the impact on staff time. Given the attract and recruit with a key strategic aim in our previous strategy. How does the board plan to deliver on this ambition in practice, particularly in light of the current financial constraints and the strict recruitment controls in place across the organisation? So a similar type.
Yeah, and I touched on that a little bit, Jan. So we are having to put in place some tight controls this year in particular. And some of that's about what we described, getting some of the fundamentals right in terms of the organisation. I think Darren's alluded to this. We've been successful in terms of recruiting. We've got areas where we're over recruited, and we're working with our teams about how we make best use of our resources across our teams. So some of the work that we're doing out in primary and community services and in things like our rehabilitation and pre-rehabilitation teams is where we've got small teams bringing them together that enable us to make best use of those resources. We will always have the trainees coming through, and although their recruitment freezes in particular areas, we will always be taking on people are coming through the training. It's really important that we get the workforce planning with HEIW right in terms of training places and making sure that we can offer all of those individuals who've gone through those programmes employment across NHS in Wales. And of course, things like the apprenticeships. We have got a really good track record of doing that. It's a really good way of giving people work experience, even if we haven't got a job just yet, because we're in a constrained period around investment, but actually giving people opportunity to feel what it's like to work, work experience from people coming through school, recognising that we do have a particular challenge around people not in education, employment or training, and enabling there to be a pipeline of people through. I also think there's an opportunity of us joining up with the local authorities around the whole workforce around not just health but care, because we are quite often recruiting staff from across the same sort of areas, and I think there's a better opportunity of joining that. So yes, we've got some restrictions at the moment while we are gripping the challenging financial position, but actually over time it's about shaping the workforce, making sure we've got the right people in the jobs, operating at the top of their licence, and that we've got really good career paths through for individuals to stay working with us for many years to come.
Thank you. That brings our annual general meeting to a close. I think we've covered a lot of ground this afternoon through our presentations, and diolch yn fawr i'n cyflwynwyr. Thank you very much to our presenters. But we do also produce an annual report and annual accounts, and those are available for anyone who wants to read across the year 24-25 in more detail. I hope we've also given you an indication of the level of ambition. Recognising our challenges, we don't shy away from them, but we do tackle them head on. But it's part of the ambition that we have for the population of Swansea and Newport Talbot to actually be the best health and to deliver the best health and care services for our population and reduce those intractable health inequalities that we've heard so much about this afternoon. So before we close, Abby and I would just like to place on record our thanks to all our board colleagues. And I said at the start, this is one of the largest public bodies in the UK. We are responsible now this year for 1.8 billion of public money, and the health and care of 400,000 people is in our hands through the decisions that we make. And no one really ever sees all the work that board members do behind the scenes. We have the set pieces in board meetings and committees, but a phenomenal amount of work goes on in people's own time because you are all dedicated and committed public servants. And Abby and I appreciate it really significantly. Diolch yn fawr iawn. So dwi'n gael y cyfarfod nawr, da ni'n mynd dweud hwyl am nawr i'n ystylwyr ar-lein. Diolch am eich cytuniau a diolch am eich amser pnawn yma, a gweld chi am y tro cyntaf and nesaf and cymerwch ofal. So we say goodbye now to all our observers online. Thank you very much for all the questions you've given us. Thank you very much for your time this afternoon, and we'll see you next time. So diolch yn fawr iawn. Thank you very much.